Hi everyone, my name is Chris Counts and welcome to our didactic on research from the RAMS Research Committee. So this topic, we're going to delve into the process of overcoming obstacles that face novice researchers if you're just getting started. I'm a PGY1 at Mount Sinai, and I'm the outgoing chair of the RAMS Research Committee. We're joined by several others today. Unfortunately, John Campo could not make it, and we were also helped by Dr. Westafar and Dr. Soares, who gave a lot of valuable input, as well as Adrian Cotarelo. So we'll go ahead and go to the next slide. So we'll do a brief overview. We have 3 sections. First, we'll talk about developing a research question. Second, we'll give you a short, not too overwhelming review of common statistics. And then we'll talk through some tips on mentorship. All right. So a good way to think about designing a research question is to take a stepwise, thoughtful approach to it so that you have a good foundation for the rest of your project. Quote we have listed here states that the most successful research topics are narrowly focused and carefully defined, but are important parts of a broad-ranging complex problem. So basically what that means is that you should think about the problem statement that you want to investigate in your research. It should further describe and refine the issue that you want to study. And more importantly, it's going to set the context of the research that you want to do. So when you're thinking about designing a research question, we like to follow the FINER maps, which is quite a clever acronym. And it stands for feasible, something that individuals at our level, residents and medical students, that we need to think about are the time constraints that we're going to have if we're getting involved in research. That's a huge part of feasibility. Second, is it interesting? When you talk to your colleagues and attendings about this, are they going to want to hear about what you're doing? You also want to make sure it's novel. You don't want to be repeating research that's already been done. And of course, you want to follow all of the ethical guidelines that have been set up to make sure that we're serving our patients appropriately. You want to make sure that the project is relevant to your daily practice and clinical care, as well as manageable and appropriate. Finally, you want to think about the potential value that this would have to the literature that already exists, and think about how systematic your approach is. An example of this is a project I'm getting involved in now that's looking at COVID, and there's not a ton of peer-reviewed research yet, so we're going to the great literature for that. I'll now turn it over to a rapid review of some common statistical tests.
Hi everyone, I'm Jeremy Carter, recent graduate of Virginia Commonwealth University School of Medicine. Again, like Chris said, I'm going to do a rapid review of just common statistical tests and their appropriate uses. I don't want to get too far into the weeds, but as a general overview, I thought some of the most important things to cover would be Ttest and its variants. So you have the sample Ttest, the paired Ttest via ANOVA, as well as Chisquare and regression. Next slide, please. So just to start off, to kind of jog your memory, we're going to look at 2 things. What is the purpose of a test? Are we comparing something, or are we looking for a certain relationship? In the comparison, we're looking for, is there a difference? That's like a control versus a treatment group, versus a relationship. Is there a connection? An example that would be door to balloon time. How is that related to patient outcome? And then we also have to look at the types of data, and I'm going to be using these words, so pay attention. Categorical and continuous. So categorical is qualitative data. Those are yes, no answers, smoker, non-smoker. Continuous is numerical, age, blood pressure, drug dose, and exam scores. Go to the next slide, thank you. So to start off with the Ttest, I'm just gonna do a broad overview and then kind of dive into everything. So when we look at a sample Ttest, we're comparing, it's a comparison, and it's categorical as well as continuous data. It compares, for the just the one sample Ttest, it compares the means of 2 groups. The paired test, Ttest, excuse me, has 2 groups before and after, so it's similar. And the ANOVA is 3 or more groups. ANOVA means analysis of variance. Can we go to the next slide? Thank you. So with this slide, I want to go through, explain the t-test. It's one of the most common tests that we use, so I felt like it's pretty important. So it compares the means of two groups, or in other words, it compares two independent variables compared to one dependent variable. And remember, the dependent variable is the variable you're measuring. The null hypothesis is usually there's no difference between the means of the two groups. And the t-test is thus called because it uses a t-value, which compares your data with the null hypothesis. You give it input, you get output. The input is your mean, sample size, standard deviation of each group, and the output you get is this t-value or t-score. And a small t-score indicates that the means are similar, so you would fail to reject the null hypothesis. And a large t-score indicates that the means are dissimilar, so you reject the null hypothesis, or in other words, they're statistically different. Next slide, please. So looking at the paired t-test, it's essentially a t-test, but with paired observations, such as before and after an intervention. And then a t-test is run on the differences from before and after that intervention. It's common for case control studies or repeated measure designs. An example here that I wanted to cover was an infectious disease physician takes on the role of decreasing healthcare acquired infections by a training program. A sample of hospital employees are selected and hand washing hygiene is observed before and after the treatment, or the trainings, excuse me. Next slide, please. So the ANOVA analysis of variance is similar to the t-test, but again, it compares three or more independent variables. And you might ask yourself, why can't we run a multiple t-test instead? Well, in doing so, that would increase the risk of making a type 1 error, or in other words, that's your significance level that you preset, the p-value, something around 0.05, or you could also see it as your willingness to accept false positive, or you could also say it as there's a difference in means when there really is no difference. And so in this example, we have three independent variables. We have, I would just say medication A versus B, and you have a placebo C. And it answers questions such as, is the patient outcome different between these three treatments, or are any of the treatments superior or inferior? Next slide, please. So with the chi-square test, it's a comparison test, and it's only categorical data. So what I mean by that is there are two main kinds of chi-square tests. You have test of independence and a goodness of fit test. And let me explain these two. So is there the test of independence, is there a relationship between two categorical variables? For example, gender and favorite color. Is there is there a relationship between IQ and Nobel Prize recipients, or political party affiliation and geographical area? The goodness of fit test, on the other hand, answers how expectations compare to observations. Are the expected frequencies the same as the observed frequencies? For example, if we flip a coin 1,000 times, will it actually land on heads 50% of the time and tails the other 50% of the time? Or if 4 medications are equally efficacious, are they also prescribed equally as well? So the chi-square test can tell us how confident we can be that our observed results compare with expected results. All right, can we go to the next slide, please? And so this is the example I came up with for the chi-squared. If we look at healthcare specialties versus preferred activities outside of work, you would assume, let's say we take 100 responses from each specialty. So if we had a total column, it would say 100 for each of the specialties. And if you look at that, you would have the expectation that people would be similar. But in reality, maybe you get something like this, where you have emergency med physicians. They look pretty standard, 2020, 2020. You have a variety of folks. Radiology folks, I'm seeing a higher number with preferred activity of watching Netflix in a dark room. And then the orthopedic surgery folks with going to the gym more often. And then, I don't know, folks also look like they like eating out more. So in order to test if this is statistically significant, rather than just an observed bias, we can use the chi-squared. Can we go to the next example, please? So regression, this is dealing, instead of, we've been talking about comparisons before, this is more dealing with relationship. In the way, let me explain that. So it determines the strength and character of the relationship between a dependent variable and one or more independent variables. If you're dealing with one, then it's called simple linear regression, whereas you have more, it's the multiple linear regression. So how this shows how one or more variable predicts an outcome. So it actually has some power in predicting, and we use the R-squared, the coefficient of determination. It's between 0 and 1, and 1 indicates a perfect fit. So let's go next slide, please. The example here, I just threw this up here as just something simple. If we look at medical malpractice claims throughout a person's career, and then we wanted to compare the number of siblings during childhood. Now, we usually always put the dependent variable on the y-axis. And who knows, maybe there's something here. This isn't real data, by the way, but if it was, it would be very interesting. And of course, it can get more complicated and can be quite useful. A recent study in Indiana was able to use a multiple linear regression model to demonstrate a strong association between predictor variables present in registration data and frequent ED use in a certain area. These researchers were able to create an algorithm from registration data to predict the future frequent ED visits. Interestingly, the predictor variables included things such as patients between the age of 22 and 44, female gender. They only had to travel a distance of 5 miles to the emergency department and had respiratory and dental chief complaints. So there's a lot that you can do with stats. This is just a rough overview, and I hope that it helps.
So my name is Ryan Pappal. I'm a rising third-year medical student at Washington University in St. Louis. I'll be talking about the difference, a very important difference between statistical significance, which we're all used to seeing displayed in a p-value, versus clinical significance. And this is becoming ever more important as evidence-based reporting of studies progresses, especially in the medical field. So when we talk about statistical significance, this obviously comes up a lot in the form of when we're talking about p-values, when we're talking about 95% confidence intervals, which was discussed briefly earlier. And this is referring to how can we trust this result? So if we get a positive result, how likely is it that this happened not due to chance? And so the p-value kind of helps examine that. But clinical significance is, given a certain result, what is the actual importance in our patient care? You can think of an easy example. If we have a massive study with an N of 10,000, 100,000 patients, looking at mortality difference between treatment A, which we're hypothesizing is better than treatment B, we might get a statistically significant result because of the large sample size. But if the purported difference is, as I have on this slide, 0.0001%, is that clinically significant, especially when we're considering other variables regarding treatment, especially if treatment A is more modern and thus more expensive, or it takes more time to implement. So the obvious answer to that would probably be no. And so when we think about looking at this, we can look at this figure which shows the difference between what point statistical significance is determined and at what point clinical significance is determined. Now, for this example, I went ahead and put that clinical significance, 10% mortality improvement is important to me and my patients in my practice. Now, that will be set based on the condition, based on exactly what's being studied. But the idea is that it's at a level that it will make a difference once implemented past the study phase. And as we can see, we can come up with a number of results. We can come up with results that show it's not statistically significant, which would be A. And it's obviously very far from our clinical significance. And as that effect size, or that percent difference in mortality, that mortality improvement increases, we get to down where we have a confidence interval like E in the figure, where it's not only is it statistically significant, being far away from the 0 point, but it is much past our point of clinical significance, which would be an excellent result. And so I added this slide for reference. I'm not going to go through each of these possibilities, but this is basically a description of what a confidence interval, which is one of the main ways we can report an effect size, can help communicate. So this is for the reference. I won't go through each one, but on the following slides, we'll actually examine once the study is out and once we have the results for treatment A versus treatment B, given a 10% improvement would be clinically significant, what would go right and what would go wrong with a PI that only reports the p-value. So on the next slide, we have the study is not statistically significant. Okay, so that traditionally when we're talking about this, we might say, okay, p is greater than 0.05. Because it's not a positive finding, maybe we don't report it at all. We're seeing a trend toward more focus on reporting these things, but traditionally we wouldn't report this because it's not positive. But let's say we're in a forward-thinking journal that is comfortable reporting negative results. What does a p-value greater than 0.05 tell us? And the answer is not much. So if we look at the confidence interval displayed here, either 1, 2, or 3, all of these carry a p-value greater than 0.05. And that's because the confidence interval crosses 0. But these each paint a very different picture. I'll compare 2 and 3 for now. 2 is not only is it not statistically significant, it's actually showing a trend away from treatment A being better, which is important information. Maybe treatment A, while more complex and more modern, is actually more harmful in some unforeseen way. But if the result is like in confidence interval 3, we actually have a trend toward a positive result, and an important trend, one that might even be clinically significant across our 10% point. And this might show, if reported, maybe we need to do a more involved study with more patients. So these are some of the things that can be shown when it's not statistically significant by using effect size such as confidence intervals. Next slide, we have a study that's reported that it is statistically significant. But keep in mind, we also need to examine that clinical significance as well. So in example 4 here, the confidence interval does demonstrate it favors treatment A by being above the 0% difference line, but it does not touch our 10% clinical significance. So this actually, while it's statistically a good result, it's not important to us, right? So this is when we're going back to that example of, oh, we found a mortality difference of 0.0001%. Well, statistically, that's great, but maybe for our practice, it's not quite as important to find and disseminate. And on the other extreme, confidence interval 6 in the figure, we show that actually it's fantastic. So instead of just reporting a p-value less than 0.05, we can now show, if our results is a number 6, that actually this treatment A is going above and beyond the 10% difference in mortality that we want to see for this to be deemed a success. So let's move to the next slide. So essentially, to kind of wrap this up for you guys, is effect size in addition or in replacement of statistical significance might be the way to go. And a lot of journals are pushing this to report confidence intervals. And some journals, I think a couple JAMA editors have actually said that p-values don't even need to be reported because confidence intervals inherently contain that p-value information. So to simplify the amount of data that's reported and is digestible by a reader, we can simplify and just say, let's report a statistical measure that contains both statistical significance as well as effect size, such as the 95% confidence interval.
So I'm going to talk to you. My name is Josh Davis. I'm a graduating resident from Penn State Hershey Medical Center. If all of that was a little bit too confusing, I'm going to talk to you about when to use a statistician to help you figure out your statistics. So there's 3 main instances when you want to use a statistician. The first one is if you're simple folk like me and none of that stuff that they just talked about made any sense to you, and you just want the statistician to kind of help you figure it out. or you don't really understand the statistics that are needed to make your complex data set work, I think that would be one instance where you need a statistician. Another instance where you might consider using a statistician to help you with your statistics is if you don't have the available software or methods to do so. So if you have large data sets, or if you're doing complex statistics that can't be done with a calculator or done in Excel, and you need to use some advanced statistical software like SPSS, SAS, some other statistical software, that would be another instance of when you need a statistician. And then the other one is when you may understand the statistics and you may have access to do it, but you're on a time crunch, or you want to delegate responsibilities and time is an issue. I think that is another instance where you may consider using a statistician. One thing that I would strongly advise against is obtaining all of your data and then dumping it on a statistician after the fact. I think not only can they sometimes not help you after the fact, but they will have a lot of good insight into what data they need and how to best format it and obtain it. If you can involve them early on in the process in what your thought process is and what your hypothesis and outcomes you're looking for, they can help you identify what statistical tests might be needed and where the data can come and what the data may or may not be able to show you. There's nothing worse than obtaining a whole bunch of data and then trying to get a statistician to run statistics only to find out that you didn't get the right data to answer the question in the first place. So I think those are some important things to consider when you're considering if and when to involve a statistician. Most institutions have statisticians available. Sometimes they have to be paid, can be paid through a department or a medical school, and sometimes they're part of a department and are willing to help to begin with. One of the things to discuss too is about kind of authorship attribution to statisticians. Some statisticians like that, some don't. I think it depends on their job roles and characteristics, but another thing that you also want to consider. And then the other topic that I wanted to touch briefly on was about mentorship. So this is a one-slide topic that has a lot of details that I'm going to go over. So mentorship is something that's going to be super important for the novice researcher. It helps you identify all of these processes along the way, as well as the more advanced processes of writing your paper, submitting to a journal. What are you going to do when you get rejected from a journal, how to get funding. There's a lot of advanced things that go into research that are beyond the scope of this presentation, but that I think the fact of mentorship is going to be very helpful, especially for the novice researcher as you're building your way and kind of advancing through your career. I think there's a couple avenues to identify mentorship. Of course, I think the easiest avenue is to look in your own Department of Emergency Medicine and find people who are doing research that is of interest to you. I think it's important to identify stuff that you're interested in and not do research for research's sake. If it's truly something that you want to do long term, you need to find something that's going to interest you to do. Other places that you can look, so you can look within your College of Medicine or graduate medical education office, and they can help you identify people in other departments. So emergency medicine touches a little bit on all aspects of medicine, and we deal a lot with the acute care of many different specialties. And just because there's not someone in emergency medicine who's doing research topic that interests you doesn't mean there's not somebody at your institution who's doing so. And then I think the other important thing to be mindful of is looking outside your institution. For collaborative research that you can do through multi-institutions. SAM is a great example of ways to do that. There is the research committee, there's the RAMS research committee. There's lots of opportunities to identify research mentors and research collaborators through different national groups or through personal connections. Obviously, we're doing this meeting virtually this year, but in the future, when we have in-person meetings, it's a great place to network and identify people to collaborate with in the future, not only to help you direct your research and help guide you through the research process, which is, as we've kind of mentioned, a process, also to identify research questions and new research questions, and also to, again, open up to different data sets and different perspectives. So people who do things at different institutions sometimes have different perspectives or insight, or different specialties have different perspectives and insight into different disease processes and or institutional guidelines, policies, instances like that. So I think we'll kind of wrap up today. Just if we were in person, I'd ask if you have any questions, comments, concerns, opinions, anecdotes, monologues, or diatribes. I guess you can drop them in the comments when we post this online, and we'll be keeping an eye on that, and we'll get back to you. All right, thank you.